All right, coming to the next ECG, a 70-year-old smoker male with resting shortness of breath. The question came that how to localize the pathway. So what they do is normally they place multiple catheters in your heart, different chambers, superior RA, inferior RA, AV node, SA node, ventricles, and then they stimulate different areas in the time, the activation from your atria to your his Purkinje bundle system. And then they are able to find out that where there's pre-excitation pathways, and then they can zap it, they can actually do ablation of that area. All right, coming to the next one. 70-year-old smoker with resting shortness of breath. So since it's a 70-year-old, we know it's a lifetime smoker. So this ECG shows a little bit irregular pattern, but you can see actually P waves. And if you see just in a single lead, there are different morphologies of the P wave. And since this is tachycardic patient, so this is a ECG of multifocal atrial tachycardia. Yes, Matt, that is correct. So non-specific ST changes are there, no real ischemic changes. So once you slow this patient's heart with either AV nodal blocking agent such as herbesser or diltiazem or verapamil, that sometimes gives a better conduction to the AV node and there's less stress on the heart. All right, coming to the next ECG, 80-year-old male with syncope. This patient lost consciousness, and what we can see is the first beat that we are seeing, sinus, QRS, T-wave inversion, a long pause, and then there is a paced rhythm. You can see the artifact and the LBB morphology, artifact, LBB morphology. So this is your native PP, or you can say the pacing artifact minimum rate setting on this pacemaker. Then there is a native P and QRS, and then you're seeing a paced beat again. So it was not sensing this native activity itself. And then there is another one. So this is a pacemaker malfunction that we are seeing in this gentleman who had a pacemaker placed. On one hand, there is sinus bradycardia. The P wave is coming really late. There are some ST abnormalities in the anterior leads that we saw. And it's a pacemaker malfunction because it is sensing and pacing inappropriately. So it's supposed to sense and inhibit itself, rather it's again capturing it. And this can be a phenomena which might be leading to patient having again long pauses and pacemaker failure leading to syncopal attack because of the native's conduction defect of the patient. All right. One more ECG. This is a 28-year-old alcoholic, homeless with a chest pain, brought in by someone who was passing by on the road and saw him unconscious, brought him to the emergency. So this is the ECG. What's going on? Is this guy having a heart attack? So there is bradycardia, and it's a narrow QRS complex, but these STs, as you can see, all over, both in lateral, 1, V5, V6, anterior, V2, V3, V4, and inferior also, 2, 3 AVF, has concave upward with the PR depression. So these are the things, especially the PR depression that you can see in lead 2, are hallmark for pericarditis in a gentleman like that. You don't tend to get MI in all the territories, but since there is anterior wall, inferior wall, and all the leads are kind of showing you these early repolarization changes, with the clinical context, it makes more sense for the diagnosis of pericarditis. All right, coming to the next ECG, 31-year-old expecting lady at 28 weeks with butterflies in the chest, has been feeling palpitations. So normally when you're doing an ECG, this ECG is a snapshot for 10 seconds of electrical activity of the heart. And as you can see, from the very beginning till the end, in the 10 seconds, we are actually able to capture a phenomena which is being shown in the last part of the rhythm strip. So initially, patient has sinus rhythm, QRS, T-wave inversion in lead V1, RSR prime, but not really that wide, still a narrow complex, so can't qualify for a bundle branch as such. But what happens is that patient goes into atrial fibrillation. All right, so that's responsible for patients fluttering. So in our clinical setting, when somebody with atrial fibrillation at such a young age comes in, we always think about rheumatic heart disease. So even though you might not be able to hear the diastolic murmur of mitral stenosis, you do an echo to make sure the chamber size is the left atrium. There should not be any mitral regurg or mitral stenosis or other findings associated with rheumatic heart disease responsible for atrial fibrillation in a patient like that. Atrial flutter and fibrillation, the flutter has actually a sawtooth appearance of the atrial activity that we see underlying in some leads, especially the inferior ones. So since we don't see that and it's not a very organized atrial activity, so we will call it atrial fibrillation and not flutter. All right, coming to this ECG. This is a 38-year-old hemodialysis patient, comes in with altered mental status and chest pain. So what do we see? All right, so you can see very marked kind of ST changes that we are seeing. Good, peak T waves and showing as signs of hyperkalemia. And we know in dialysis patient, these things do happen. So hyperkalemia, that is correct. And then there is an MI with it, ST elevations that we are seeing. He came with chest pain. There are reciprocal inferior ST depressions that are seen. So it's an anterolateral STEMI going on in the face of hyperkalemia. And of course, the PR interval is also deranged, although it's a sinus rhythm. So because of the electrolyte imbalance, the whole conduction system is under jeopardy. This patient needs both STEMI treatment as well as hyperkalemia correction. All right, coming to the next one, 51-year-old male with shortness of breath and PND. So what do we see here? Yes, ST elevation in AVR normally tells as if there is extensive ischemia going on. So most of the time, AVR ST elevation is a grave sign. Either there is triple vessel disease or there are signs of really left main disease that are shown when AVR is especially elevated. So what do we see here? Sinus rhythm, right? So there is a P wave right here, another P wave right here. So there's 2-to-1 block going on. One is a conducted and the other one is unconducted. The PR interval is more or less the same in which there is conduction. Axis, one is negative, AVF is upward, so right axis deviation. It's a left bundle branch morphology, a wide complex. Yes. So left bundle, 2-to-1 AV block, right axis deviation. These are the diagnoses that I want you to be able to ascertain when you're looking at an ECG like that. All right, I believe this should be the last ECG. 55-year-old male with severe chest pain, nausea, vomiting, so typical ACS presentation. But apart from the symptoms, there is a disparity in the blood pressure of the patient. The left arm is 190 by 110 and right arm is 100 by 60. Looks like a late presentation. Already large Q waves are there. Right. Aortic dissection, very good. Wallenstein also, but normally that's deep T wave inversions that we are seeing this cove appearance in V2, V3. It's a grave diagnosis. The caveat is that if you're really thinking of dissection, giving an SK or TPA would worse the situation. Doing an angiography would also be a worse situation. So unfortunately, analgesia, nitrates, beta blocker, and CT angio is warranted because you want to actually see this the segment of aorta which is involved in the dissection of this patient. So this becomes a really difficult case to manage when you're seeing patients like that, especially if you're thinking that the dissection, the flap of the aorta might be closing the ostium of your left main and causing STEMI-like changes with Q waves, anterolateral ischemia. So really bad sign, bad prognosis for the patient in that situation. So the tips are, I'm going to go over, we went in the first one as a recap. Look at the P waves. They should be upright in 2, 3, and AVF. Whenever you see that, you call sinus. So you'd at least tell what is going on in the atria, what the atria is contributing in the electrical segment. Wide complex versus narrow complex. Whenever there's wide, look at the shape in V1. If it is a large, broad-based pattern like this, it's a left bundle branch block. And if it is a RSR prime in V1, then it's a right bundle branch block. Look at the axis along with it. And for that, you need to look at lead 1 in AVF, and that will tell you what is the axis. And then you can define whether there is a left anterior hemiblock or posterior block based on the axis along with the bundle branch block. All right. You should always develop a methodology to dissect the ECG, look at the complexes one by one. Think separately what is happening in the atria, what is happening in the ventricle, and if there is an irregularity, the PR interval should be variable. If there is no P wave, think of AFib. If it is really a regular kind of rhythm with no P wave, think ditch toxicity. ST segments, whenever there is depressed or elevated, think in terms of coronaries. If there is LAD, think anterior versus 2, 3 AVF and inferior. And whenever there is an ST elevation and depression at the same time, always focus towards the ST elevation. So axis, the only important thing is that it helps you see what is the resultant electrical vector in which the electricity is flowing from the atria to the ventricle, and it should be downward and toward the left. And pay attention to the clinical context, because that most of the time gives you the real picture of the ECG finding, which is denoting the diagnosis for you. Treat the patient, not the ECG. Many a times we are given ECGs with real bradycardias, but actually it's just the settings on the ECG. The paper is being wiped out at 50 millimeter per second, and that's what seems like as if there is a real bradycardia, but the heart rate and patient is feeling fine. Make sure that whenever you're seeing ECGs of a patient, it's the right patient with the name and demographic information, because you don't want to spend time on wrong ECG for a wrong patient. All right, with that, I finish, and I really appreciate your all paying attention for these 45 minutes. Thank you very much.